now do the sharing, sir. We have made you as a co-host.
Okay.
So you can actually share it now.
Okay. How much that? Yeah, okay. We need to share this one with them.
But the students are they are biomedical engineering students. They are final year students, isn't it?
Sir, it's the biomedical students, second year, third year, and final year, and faculty members from our institute and other institutes also, from various departments.
Okay. Okay. So
my experience in the department.
Yeah, you can.
We often.
Yeah.
Sir, can we start formally? We will go ahead with the formal introduction. We'll start formally, sir. Can we do it?
Okay.
Yes. Prabhakar, please go ahead.
Yes, sir. Sure. So, Lakshmi ma'am, yes, ma'am, you can start, madam.
Sir, can you hear me, sir?
Yes, we can hear you, ma'am.
Okay, sir. A very good afternoon to one and all present here. On behalf of Department of Biomedical Engineering and Department of Training and Placement, Arupadi Vidi Institute of Technology, Chennai, I welcome you all for the international webinar series. In the morning session, we had a fantastic talk on EEG monitoring and applications. Now, we have a webinar session on Parkinson's neural disorder and its treatments. In this regard, I would kindly request Dr. M. Ravindran, Professor and Head, the Department of Biomedical Engineering, to present the welcome address.
Thank you, Lakshmi ma'am. Good afternoon, one and all present for this webinar, and I welcome you back from the morning session again now. And morning we had a talk by Mr. Mauli from Penn State University about EEG analysis and applications. And now we have a wonderful speaker, Dr. Pulohanathan from UK, and he's going to speak about Parkinson's and its treatment. Parkinson's is a neural disorder, which actually is a very important and prime topic for biomedical engineers to understand about it. And once we understand the medicine part of this Parkinson's, we can work on the engineering applications. So that is an idea. That is the idea of what we have planned. And on this occasion, I would like to welcome our speaker, Dr. Pulohanathan, and all the faculty members and the participants for this webinar series. Thank you, ma'am. Please kindly go ahead with the proceedings. And I would like to have Professor Lakshmi Mohan, who is with us, to give few words about this webinar and his thoughts on it. And we are happy to have you, Professor Lakshmi.
Yeah. Thanks, Dr. Ravindran, for the invitation. Great pleasure to attend this seminar. I would like to congratulate all biomedical department faculty members and students community for arranging this kind of seminar. I take immense pleasure to welcome our beloved friend, philosopher, Dr. Pulohanathan, to this great occasion. Thanks for your acceptance, sir. We have been traveling. So many institute and conference also. We have attended so many conferences, and you are the great guide for me. This is a great opportunity to all biomedical, and medical science students. Dr. Pulohanathan has fantastic opportunity to our biomedical students and biotech students and medical science, allied health science students also. This is because of continuous follow by our beloved HOD, Dr. Ravindran. We got this kind of great eminent person from UK. Thanks for accepted our invitation, sir. Thanks, Ravindran, sir. Once again, I would like to thank Dr. Ravindran and Biomedical Department. Welcome, Dr. Pulohanathan, sir.
Thank you so much, sir.
Thank you so much, sir. Yes,
Thank
madam.
you, sir. Now, I request Ms. Santoshni Arunvallal to give a brief introduction about our today's session speaker, Dr. Saravanamuthu Poologanathan.
Yes, ma'am. Thank you. Dr. Saravanamuthu Poologanathan holds the position of Family Physician, UK General Practitioner with extended role, setting up his principal career as Family Medical with Surgical Dermatology as special interest. Dr. Saravanamuthu Poologanathan holds meritorious credentials on his qualification, where he received his first degree on Diploma in Civil Engineering at Caterpillar University in 1971, MBBS in Faculty of Medicine at University of Colombo in 1972 to 1978. He holds many accolades on this post-graduation like Diploma in Immediate Medical Care 1989, Fellow of the Royal College of Surgeons 1994, Fellow of the Royal Australian Colleges of General Practitioners 2009, Fellow of the Royal College of General Practitioners 2015, Certificate in Primary Care Skin Cancer Management 2009, Fellow of the College of General Practitioners Sri Lanka 2018. He has 40 years of experience in clinical profession with experience in general medicine, anesthetics, and special interest in minor surgery. He also has experience in managing healthcare team consisting of clinical and non-clinical staff in running a busy general practice. In undergraduation domain, he is an accredited trainer for final year medical students of a number of London-based medical colleges at undergraduate level and an OSCE examiner for UCL. In post-graduation domain, he is a trained PG Family Medicine MD trainees from Sri Lanka's PGIM. He is a trained PG MSc in Family Medicine, Baths and London School of Medicine. He is also a peer reviewer in community-based medicine educators for Baths and London School of Medicine and Dentistry. He is a past F2 trainer for London Deanery. His experience started with internship at General Surgery, Obstetrics and Gynecology at Batticaloa District General Hospital, Sri Lanka, and moved to SHO in General Medicine, Psychiatry, Batticaloa District General Hospital, Sri Lanka, ENT, Colombo General Teaching Hospital, Sri Lanka, Neurosurgery. He served as a registrar at Colombo General Teaching Hospital, Sri Lanka, Neurosurgery. He served as a clinical assistant at Hartlepool General Hospital 400 sessions. He also served as SHO at Hartlepool General Hospital in Accident and Emergency, Orthopedics and Trauma, Urology, General Surgery, Anesthesia. He also served as a registrar at Royal Victoria Infirmary, Newcastle, training in Intensive Care and Old Church Hospital, Essex Locum, in Intensive Care and Anesthesia. He also served as GP trainer in general practice, Barlow House Medical Centre, Milford Haven, South Wales. He served as a deputy doctor for Healthcare Limited, Southend, and part-time anaesthetist for Havering Hospital Trust. He also served as a clinical assistant in Southend Hospital, Accident and Emergency, and Old Church Hospital, part-time accident and emergency. Now, currently, he is a family physician at Rush Green Medical Center, a medical practice with registered patient population of 3,500. His extracurricular activities includes Overseas Secretary, Medical Institute of Tamils UK, a UK registered charity involved in health education and healthcare charity, Director of Institute of Family Medicine, Jaffna. He's more passionate about creating family medicine centers and training physicians to provide a holistic care to local communities. We are very much honored to have you as a today's speaker for our webinar session, sir. Now I kindly request Dr. Saravanamuthu Poologanathan, sir, to please take over the session.
Thank you very much for the quick introduction. Finally, after doing all these surgical jobs, I ended up as a family physician in United Kingdom. Probably I am fortunate to have a connection with Professor Lakshmi Morgan in one of the conferences in Chennai and Kuala Lumpur, and that makes our friendship started about 2 years ago. Then Professor Lakshmi Morgan visited to Jaffna, and I took him and showed from Colombo to Jaffna and the work we are doing in Jaffna. And also then we visited Arbor David Medical School and Technical College. And I was very much privileged to have a reception there by the staff and other dean and everybody was there. Then later, the corona, I was supposed to come on March 11 to Pondicherry. Unfortunately, corona stopped us. I couldn't travel, so I had to postpone to September now. Probably by September, I should be able to come and see you all. In fact, after I visited Arbore, I was able to come for the Tamil conference which took place at Pondicherry Medical School. So I visited Pondicherry twice, and we hope we can improve the relationship further and further. One of the things we are trying to do is to make a link between the Pondicherry, Jaffna, and London on medical education and other academic activities, like talking to the biomedical students is one of the activities. To tell about the charity I am working in London, it is called Medical Institute of Tamils, which is 30 years old now. So we started in 1989 to educate the overseas doctors who come from India, Sri Lanka, and other countries from Far East, South Asian doctors who come to UK. We started teaching them for their lab examinations, and we gradually grow, and we are doing a lot of activities. This is part of our promotional activities and our service to the humanity, mainly the Tamil-speaking community around the world. So we got a network of in all the countries where Tamil lives, like USA, Canada, Norway, European countries, including Norway and Switzerland. And then if you go to Southeast, Malaysia, Singapore, Australia, and New Zealand. So we have a network of many medical community. We have a lot of network, and we have several conferences meeting. And I was fortunate to be an overseas secretary for MEAT up to last year. And I was a president in 2003 and 4 for this organization. Currently, I am an editor for the Medical Institute of Tamils. And the person next to me is Dr. Shankar. He is a current overseas secretary. In future, he will also get engaged with the teaching to your university and technical schools. Right now, I start the topic. First, the topic is about Parkinson's disorder, which is, of course, this disease is very important. For us to start the introduction for us to have a happy life, we should be able to walk well. We should be able to speak to others, and also we should be able to mobilize. And the Parkinson's disorders affects all the three functions are affected on Parkinson's. So the main problem with the Parkinson's, next slide. One before that. Yeah, the Parkinson's disease, by definition, it is a second most common neurodegenerative disease affecting 1% of the population over 55 years. Probably it's a disease related to aging. Most of the people after 55, your certain abnormalities taking place. It's a degenerative, means gradually it's a wear and tear process. Like a car, when you use a car, when you get older, it's has wear and tear, tire, stones, engine change like that. Our body also can't go on too long. There will be a wear and tear. Here is a neurodegenerative disorder, means the nervous system get affected. So disease characterized by there's a nerve endings. You would have heard about engineering students. I don't know how far you know about this nervous system. The nervous system have a conducting system. It's like an electric wire, and it's connected. And in between two junctions, there's a conductor called neurons and the receptors and the transmitters. So in our brain, right, there's a thing called dopamine. Dopamine is a transmitter from one nerve ending to another nerve ending, another nerve. So there will be a problem in this dopamine. That means a dopamine, with the aging, the dopamine level is going down. So when it's going down, your motor activities also get less and less. So one of the symptoms, if you look at the cardinal symptom, there are 4 cardinal symptoms in Parkinson's disease. First thing is tremor. Trusting tremor, people while you are sitting, their hands are shaking. That's the early sign. Then the motor activity could be less, called bradykinesia, their movements are less. And also, while that happens, we only have to use our organs and the muscles, otherwise it becomes rigid. So because of the slowness of the movement, your muscles become rigid. And all these things cause a postural instability, means you become stooping and your walk will get slow. So this affect your face. When you affect your face like a mask face, no, the mask face means you can't smile. They won't smile because the muscles have become rigid. So these 4 symptoms are the cardinal symptoms. That means these are all important for our normal day-to-day life. You have to move around, you have to talk to people, you have to smile at people, and again, these are the main features. Other than that, there are other additional symptoms. These are called motor function or mobility functions are affected. Other non-motor functions like your brain function get less, your thinking power getting less, and in fact, your people get dementia, and also they get depression. These are not related to motor function. Like that, it affects the whole body. Like it affects your swallowing. You find difficulty in swallowing. Even your bowel motions are reduced, so people get constipations. And because of all this mobility less, your blood pressure get low. So when the blood pressure get low, then people tend to have falls and break. So those are secondary effects. The main effects are due to those 4 cardinal signs and symptoms. So what's happening? Our brain is like a computer system. You are all very familiar with the computers. So our brain is also a computer, and the mobility part is happening at the deeper part of the place, the blue spot, that is called substantia nigra. So that's a place this motor activities beginning. That's the center, that's a head office for the motor activities. So that the dopamine depletion affects all the motor activity getting less and less. If you look at the next picture, the healthy brain there, that is a normal healthy brain with a substantia nigra. In Parkinson's disease, it becomes smaller, and also all degeneration becomes smaller and activity getting less. You go down, that's this is a neuron structure. There's transmitting neuron and receptor cell. The one in between is called junctions, called synapse. So there's a substance called dopamine. That's a chemical that's transmit from electrical signal, change to chemical signal, and transmit to the other one. So that get depleted. So that is a main problem in Parkinson's disease. So the Parkinson's patient, dopamine is depleted. So when it's depleted, all your activities get less, motor activities get less, and also other secondary effects takes place. So now I can go further. Next one. So Dr. Shankar will do this slide, pathogenesis of Parkinson's.
Okay, thank you very much for hosting us, and glad to present with Dr. Pulo. The pathogenesis mainly that as you remember that most of the Parkinson's patients develops over the age of 50, but there's less than 10% of them can start with the age of 10 itself. Then majority the sporadic onset. There's no genetic causes, but regardless of that, there's about 15% of the Parkinson's disease associated with the log2 or SANCA genes, SANCA. These genes can express either one or the both. These are mostly autodominant dominant patterns. This means one allele alteration itself is to induce Parkinson's disease. In the slides, you can learn these things later. The other cause for the Parkinson's disease, beside the genetics and the idiopathic, is just organochlorides inside, i.e. the most common causes that DDT, which was banned in the Southeast Asian countries, 1970s and 80s onwards, in Africa and other places. We use it for controlling the mosquitoes and things like that. So banning that, as the clear indications, if you can, National Institute of Environmental Health Sciences indicated there's a clear correlation to that one. The other one is diet also. The diet, how this happens is if we eat highly unsaturated, polyunsaturated fatty acids, in Tamil, which is called nalleണ്ണ, or just sesame seed oil, olive oil, and things like that. If you eat them, omega-3 fatty acids in seed, indeed, and then that it'll reduce the chances of getting Parkinson's disease later onwards. Same, but low saturated fatty acids, like especially the Western diet is not the best one for Parkinson's disease. So if you reduce the saturated fatty acids, i.e. Mediterranean diet or Asian, Southeast Asians, olden days diets, it lowers the development of Parkinson's. The recent studies shows here, animal studies, there's a 25% reductions in developing Parkinson's disease. If people tend to have caffeine in there, it's a protective effect itself. You can, if anybody wants to share the things, then you can look it, and then Parkinson's disease affecting caffeines. Parkinson UK also advocate this one also. This is reduce the risk for it, Parkinson's disease. So there are food. One is idiopathic, old age related, and then the genetics 15%. Then the diet will reduce the risk of it, as well as the caffeine itself. Okay, I'll pass Dr. Pulov to explain the next one.
Okay, the management of Parkinson's. The olden days there was something is depleted, so we had to replace it. So there are medications. So levodopa is a well-known drug that is actually it's a dopamine equivalent. So that is given as a drug. So usually I am a general practitioner, family physician. I see that we are seeing in Britain there are a lot of elderly population. The Parkinson's is more common because people live longer here. So Parkinson's are common when usually as a GP I see the patients for long time. In United Kingdom, the patients are registered with us. If any problem, they have to go to the primary care physician. That's a family physician. I am a family physician. So I see sometimes the patient of 4 generations are my patient. They are in my list. So they come for 20, 30 years, and I know what they were doing in the past, and suddenly they become slow and their speech getting slow. So early stages we can detect. As a GP, as a family physician, I have an advantage of spotting them because I know their social life also. So sometimes they were talking very fluently. Now their speech getting slow and slow. You can remember Sri Lankan Tamil leader, the S.J.V. Chelunayam, Father S.J.V. Chelunayam. He's a Parkinson's. So he was giving a very excellent speeches, and later on his speech becomes slow and slow. That's the early stage. The speech getting slow, and their facial movements become mask-like. Their movements get less. They won't smile. They come. So it's easy to spot them if you are seeing them more frequently. Easy to spot them clinically. You don't need any investigation or test to spot that one. Also, their gait becomes slow. So the medications, first I said the levodopa. So when we spot them, this chap got a Parkinson's. Usually when I said Parkinson's, English people, they will ask, why, how do you know that? And I said, it's my experience. I have seen people. So they will ask, can't you do any test for that? There's no test. It's a clinical test, means you have to see you by experience. We know that you are developing Parkinson's. So there is a way we can reduce your symptoms. We can't cure Parkinson's in the way, but only thing we can reduce the symptoms. That means your mobility can be improved a little bit. So we started a tablet called Cinemet. That's commonly used here. I hope that's available in India also. So we started the Cinemet twice a day, daily dose. We start that, and we follow them up. So usually for some more years they should be all right. They will go on with the tablets. And there are a second group of tablets called dopamine agonist. This is a tablets that stimulate the secretions of the center. They're called dopamine agonist. Then there are other drugs which may be important. These are the biochemistry people. They will know that there's some enzymes you either block the enzyme or stimulate the enzyme. Some of the enzyme destroy the levodopa, so that either we have to some mechanism to stimulate, to increase decrease the destruction rate or increase the production rate. So those are other 4 group of drugs. So we try the medication, but there's one thing you can't, by using the drug, we can improve the signs and symptoms they are having, but the progression of disease will be continuing as age goes, it continues. Finally, you can't completely stop it, but we can improve the quality of life. So you give the tablets, and the tablets, of course, you try for some time. After some time, nothing won't work. Particularly, they got the tremor. Tremor get worse. It can be distressed, and they keep on shaking the arm. That lose because when they keep moving, they lose energy from the body. All what they eat, the energy is getting wasted by these tremors. So because of that, they lose weight. So those are things to prevent. So there are after we treat it, after some time, there should be something else you can do. These are called medical treatment. So next thing is to come to surgical treatment. Now they were doing this deep brain stimulation called DBS. The late stages, when the symptoms are not controlled, there was a thing, give a little bit of current into the brain, whereas the center is there, you stimulate with a current from outside. So that is called deep brain stimulation. So there are certain, you don't need to do it on everybody, and you can't do it on everyone. There are first thing, it's not indicated, and also there's not too much of facilities available to do, but they are doing selected patients on a deep brain stimulations. Next slide.
Okay. There are other supportive theories also there. Treatments, occupational treatments in early days, speech and language for swallowing and speaking, and diet advice, as Dr. Pulo mentions, increasing small amount of salt in diet, frequent small meal also will helpful. In this one, DBS current developments, we'll talk about the main topic is DBS as a surgical procedure in 1997, just first introduced to reduce the Parkinson's disease tremors, symptom control. Just like the pacemaker itself, similar to pacemaker, it just as Dr. Pulo mentioned, you're giving the current thalamus and the subthalamic nucleus here. This is just the STN, which is what is in the red dot. We'll go to the next slides and we'll show you in details. And targeting the STN is the more important, because if you put this in the proper positions there, in the STN positions, or the second point also there, and then it will reduce the need for the medications. So important to put the leads in the correct placements, and also that the lead needs to be, you can put the second lead also right on the subthalamic regions, and then that will also reduce further if there's more symptomatic things. Beside this one, now that Duke University in 2017, now they are experimenting biomedical engineering point of view. It's called light-based brain stimulation treatment also, which is exactly the DBS itself, but it's just a little bit more advanced, and then that in future they might be coming as treatment modules, which is essentially using viruses with the dye, and then injecting the patients inside, and then MRI, CT scan, and then following through that to stimulate or to control the centers which is producing abnormal electrical impulses. Okay, next slide,
Okay.
Dr. Polo.
In 1997, they approved for this DBS, deep brain stimulation, only for the tremors, disturbing tremors. They tried in 1997. Probably they would have done, but its approval was given on 1997. Then in 2002, they thought it's an advanced Parkinson's system. That means they couldn't control with the tablets. It's advanced disease. The DBS was tried on patients. And recently, the 2016 only, they thought it can be done even at the early stages, early symptoms. You could try DBS. So people, once you have the treatment, people with Parkinson's disease, at least they have a better effect, at least for 4 years. That was the findings. The people, those who don't respond to the medication, you can start from the beginning. So it entirely depends on each country and their wealth and the health system, how it works. So probably Western developed countries, they're trying to, places like UK and USA and other developed countries, they now try to do in early stages. Right.
Okay. As Dr. Puro mentioned, that is essentially because it's a very costly procedure to do it. So we discussed in the previous slides, there's a thalamus here in the cerebral cortex where the brain sections, then is the mesocephaline area, also the SN. SN is substantia nigra, which is substantia nigra is a place, if you imagine the fingers coming, all the nerves from the cerebral cortex, like each nerve system's coming in, and where the relay system is the substantia nigra itself. The dopamines there is to fast forward the connections there. So depletion of the dopamines causing the problems. So ablations of the abnormal signals coming from the cerebral cortex, which is that in a DBS itself. STN is the substantia is here, subnucleus subthalamus is where the first they started inputting the electrode itself. And if this is sufficient, they leave it with the patient. If that's not sufficient, then they go to the GPI. GPI is globus pallidus internus. There's a global pallidus externus also there. So you got to be, as a neurosurgeon, as Dr. Pulo used to be, you got to be extremely careful in putting the electrodes in the specific locations. If a little bit of margins errors comes in, then it wouldn't give the proper control of it. The treatment will not successful. So hence that patients will be feeling very sad after paying so much time and everything else, and then they feel often depressed. Okay, and one moment. Okay. Dr. Pula will discuss about the method.
Method surgery, as first step one, you have to attach stereotactic frame. So the picture is there, no?
In the previous slides, we'll show you the stereotactic frame itself. The very first one, you will see this is the stereotactic frame, which is attached to the head.
So first thing, it should be done on a tertiary hospital. They don't do the secondary care hospital, tertiary care hospital. There should be a neurosurgical procedure, intensive care unit, all should be there. So next slide.
Yeah. Okay.
Right. So you should have either MRI or CT scanner should be there. So then you need a human resource like a neurosurgeon and the staff nurses, theater. So make a small incision or put a burr hole in the brain. Burr holes you can put either temporal, parietal or frontal burr holes. Then you have to insert a electrode through the brain. But of course, as I said, even a 1 millimeter difference, if you go and stimulate some other places, the effect won't be there. So you must exactly know where the substantia nigra is. That, of course, a person who's experienced, he will do it. And while they are doing, they look at the electronics gadgets and see that there's the right place. And also, then they give a stimulate, and nowadays even they think about doing from outside, stimulus from outside. That's a new method. I think those days brain stimulation, they stimulate with a stimulator. They implant something and then give a stimulus from outside. Okay, so that really the basic principles. These are the things you need. A pacemaker consists of an electrode and a lead wire and pulse generator. So put the electrode inside and connect the wires and stimulate. The patient can on and off with the generator, pulse generator. He'll hold it, and we'll tell the patient how to do that. Okay. So these are some of the pictures of the procedure, how they look like.
So here you can see the frame, how it's fitted before the surgery. And during the surgery procedures, drilling with the frame itself and things. And the burr holes Dr. Pula mentioned, parietal things. And then you come all the way with the electrodes straight through without disturbing the other part, subthalamic regions. This is going to the second part of it, the two sections you can put it on. So it's just very crucial. 1 millimeter itself is very crucial. Things is the precision is the most important thing in the neurosurgery part of it. This one. Okay, wait for the next slide. One moment. The transitions.
So one, as anything, when the procedure, surgical procedure, it has its complications also, no? So usually, we have to tell the patients, explain what are the complications. As usual, any surgical procedure has an infection, risk of getting infection. You can end up with, by you don't aseptic method, it can get infection. Then also, there could be bleeding. If you go and bang a artery or vein, then it starts bleeding and the patient will end up with a hemorrhagic stroke. Or even without that, the stimulus have gone in the wrong place and stimulates the wrong place, the patient end up in a stroke itself. Then is a process, the procedure may be unsuccessful, it may be not working. So these are the expected complications.
Okay, there are limitations for the DBS surgery. As we mentioned before, it's quite expensive. And the patient selections is that, they should not be used in following patients. Like if somebody had the ablation procedures done, DBS procedure done before they're not the candidate, the patient is pregnant or expecting to be pregnant, or under the age of 18 or 75. The reason is over 74, 75, motor degenerations are quite significant. That's not going to be very helpful for the patients themselves. Okay, as Dr. Pulo mentioned, these are the risk factors. He mentioned the intracranial bleeding, seizures, headaches, infections associated with the surgery, device probe replacements, i.e. that mentioned that if that slight difference into 1 millimeter or less, and then you had to replace the probe again, so that you had to go back into the surgical theater and then do that one. Wire replacements and repositioning the probes, placement of the pulse generator within the area, subcutaneous areas. There is also risk in any surgery association, 1% of the less risk associated with that one. Yeah. Sorry. Okay. Dr. Pulo?
Right. He's just trying to give some examples. Can you play the video?
Yeah. Sure. These are celebrities. One moment there.
Those who had DBS.
Yeah, DBS. Michael J. Fox is an American big celebrity. One moment, the mouse is coming back live. Okay, and then he has been a childhood, for those who knows about Back to the Future, the movies and things.
How do you reach the top of search results? Increase your website's visibility with the
Michael J. Fox and all his roles, but Back to the Future. Can you believe it? That movie will celebrate its 35th anniversary next year.
Unreal. And the legendary Michael J. Fox. Now, and brother, it is cold out here in New York, but you said you're Canadian. You don't need no coat.
I'm Canadian. This is a beach day.
And when you see that clip, Back to the Future, like what kind of memories does it bring back?
Hazy ones, but it was such an interesting thing making that movie, because I was making the movie and I was doing traditional family time.
Oh yeah, we'll show called Family Ties, only our favorite.
I mean, it was 35 years ago.
You can see the poverty of movements, yeah.
But I did both things at the same time, so the process of shooting the movie was kind of a blur to me. Yeah. I finished the movie, people said, "How is it?" I said, "I have no idea, I have no clue." And I saw it and I said, "It's pretty good."
Pretty good. Pretty good. People still are in love with that movie.
It's crosses generations about it. I just think I think that simple idea of what was my parents' experience when they were my age. It's a hook that lasts forever. Every generation is interested in.
Look at his face now, and look at his hand, this small tremor. It's called pill rolling tremor.
Serious damage.
They do pill rolling tremor.
We go just doing it anywhere.
Did you ever drive a DeLorean in real life?
Well, I drove that DeLorean. There are like 19 different kind of versions of it. refrigerator's cut in half that way, refrigerator's cut in half that way, refrigerator, there's no top on, so you get the camera and get on the angles. And every one of those variations had some aspect to it that injured me. But either cut my hands or bang my knees or second my back. It was fun.
If you head to Times Square right now, there's a whole nother version of the DeLorean, but that's for another day. It's holiday.
Download driving?
Download Cookie Monster.
Yeah. You know what's cool too is our studio is at Universal. Have you ever gone up to the Back to the Future set? Can you imagine Michael J. Fox just strolling around under the clock tower right there? We got to do this with you.
That'd be pathetic.
People have to, like, if you're ever walking a street in New York or anywhere, people have to shout. Back to the Future. What do they shout at you?
People in New York are like, hey, Mike, how you doing?
How you doing?
We're getting a cup of coffee. People in me are real familiar. It's funny. They don't.
Fast food.
Your big event this past weekend. Who were the big guests coming out?
Well, we had Joe Crow.
You can see a tremor in the hand. That's it.
Tom Quinn.
Okay, of course, and then go to the next one.
Okay.
Okay.
So he was a very active man as he grows older and older. The next video, you see a chap who had before the treatment of DBS and after treatment. So the second one.
Yeah, one more.
So while
Sorry, one moment.
Okay. So while this, what are the benefits of this treatment, DBS? First thing, we tried 1 tablet, 2 tablets, 3 tablets, still not working. The symptoms are not improving, then we recommend for DBS. So one of the way, sometimes reduce the medications. Still they may need medications, tablets. So tablets, of course, any tablet you take, it has a side effect. So they have a lot of side effects with the Parkinson's tablets. So DBS have an advantage of reducing the dosage and reducing the side effects. And also the electrical impulse can be adjusted. Of course, you could be expert on that electronics and electrical things. So that can be, you can increase the frequency, dosage, and everything can be increased and decreased, depends on the need. And also, so most of the people have, heart also, it works on electronic things. So some people have a heart problem, conduction problem, they have a cardiac monitor. So you can have both cardiac monitor, pacemaker, and also you can use this also. Can be used simultaneously on the same person.
Okay.
So can you get for the next?
Yeah. Sorry, just there's technical issues with slides. No, Hamilton. Yeah. We'll ask for the IT persons to intervene for one moment. It's not moving the slides.
Right. In the meantime, while we are doing the video, in one more video to show you.
Slides. Go back to the previous slides. Okay. Play this one video, the last one. Yeah. Thank you.
Right. This gentleman, before treatment and after treatment with DBS. See where is it?
It's February 22nd, 2013. Just a couple questions for you, sir. You started having a tremor in 2005, is that correct? That's what our records indicate. Correct. Okay, and you've never been on medicine, right? Correct. Okay. Let's just do a few tests if you don't mind. Can you tap your left fingers for me? As best you can. How about open and close them like that? Try to open and close like that. Okay. Let's see you walk a little bit if you can. Okay, I have to stand a little bit away from you. Hold on. Okay. Okay, all right. Let's turn around and go back. Be careful now. Okay, sir. So can you tell us the date today? Today is October 16, 2015.
Okay.
And so we've been kind of gradually increasing your medicine over the past couple of years, and you've gotten a lot better, haven't you?
I really have.
Okay. Well, let's see you try to do some tests that you had trouble doing last time. Can you tap the left fingers like that? How about the right? Okay. Oh, great. Now let's see you walk. I'm going to open the door here. Okay. Can you walk towards that door?
This after treatment.
Okay, and turn around. Can you walk like this, heel to toe, like you walk in a tightrope? So how do you feel now compared to 2.5 years ago?
It's like night and day. So, a year ago, I couldn't scratch the top of my head. And today, I get up, I do all my ADLs and walk and exercise. I'm back in the land of the living.
Fantastic.
So to summarize, the Parkinson's disease, it is actually it's a degenerative disease. That means it's a wear and tear process of the body, and it's quite common when you get older.
See important safety information at the end of the video. Only your doctor can determine if this therapy is right for you.
Okay. So the disease, first diagnosis, we don't do any sophisticated test to diagnose. It's just your sense, your medical sense or clinical sense. It's a clinical diagnosis and the familiarity of the patients. Then once you diagnose, you start with a medical treatment. Medical treatment, of course, it doesn't stop the disease, but it stops the symptoms or reduce the symptoms for medical treatment, at least to have your normal lifestyle, day-to-day life. The symptoms are distressing. So to reduce the symptoms, the treatment is given. And the recent one is the surgical therapy. Deep brain stimulation is a surgical therapy done by the surgeons, neurosurgeons particularly. So again, I will say that the surgical treatment doesn't stop the disease or doesn't stop the further deterioration, but it reduces symptoms. So I don't know how as a biomedical engineering students, the surgical part you will be interested, but you know what is the problem. No, then only you can go further in your education and thing. So with that, if you want to ask any doubts, any questions, please ask now. Hello?
Can you hear us?
Yes, sir. Yes, sir. You are able to hear, sir. Students, if you have any queries, you can raise your hand so that I can allow you to talk. Or you can put your questions in the chat box. We'll have a discussion.
So anybody want to make any comments? Anybody, any doctors there?
Yes, I guess Munnan is raising his hand. I'll just allow him to talk. Yes, Munnan, I think you can unmute yourself and you can talk. Mohanad, sorry, Mohanad.
Question
Mohanad, I think you have unmuted. If you have any queries, you can ask.
Hello?
Hello, Mohanad? Yes, muted. Yes, students, anybody have questions, can ask.
They are Tamil speaking people or?
Yes, sir. It's a mixed population, sir. Many people will be Tamil and yes, sir.
Okay, we'll talk in English.
Sir, one question is there in the chat box. So is it possible to cure this disorder only by medication, sir? Or is there any other possibility to cure this disorder?
There's no, because something is depleted in your brain. So replacing, and you keep replace it. But again, it gets exhausted after some time. No, it may work initially. That means you may, but it is not possible to cure it. That's obviously, but you can reduce the rate of deterioration by medicines. So after some time, the medicines work won't be that effective. And only they are talking about surgery. Surgery also is to reduce the symptoms. For example, the tremor is a nuisance, no? And some people become too rigid, like they go like a boat. They can't even swallow because no muscles will be functioning. So it is not, the answer is it's not curable, but you can reduce the symptoms.
One more question is this, sir. What's the time period required for the treatment of this disease?
What is the
time period required for the treatment of this disease? That's curing to a certain extent.
It's
So
a
how much time period it takes?
Lifelong treatment with the medications. You can't stop it. Once you stop, they become rigid or the tremor get worse. So the treatment for tremor, there's a different way of treating, and for the rigidity, there are a different way of treatment. And again, if you over-treat also, that causes problem. So you have to give a right dose, and you have to continue the treatment. You can't stop it here.
As you've seen, Dr. Pulo mentioned, Michael J. Fox got the juvenile Parkinson. His onset was before 30 years of age. Then he had to be continued to treat, and deterioration is going to be there. The only way to do is preventive measures to reduce the amount of deteriorations, which is food, diet, exercise, and things. They may play a role, but then they're not going to be stopping the Parkinson's disease from developing.
Fine, sir. Fine. Sir, I have one question. Is there any small exercise that can be done in prior? That means in our middle age, just to avoid this type of Parkinson's disease at the age. Is there any exercise so that we can practice it daily? So one point of time, at least we could postpone this type of Parkinson's coming into the earlier stage. Is there anything like that, sir?
The postponing means once the disease, if your muscles, if you have a normal activity, if you lie down in the bed for about 2 days, all your muscles function, you can lose it. That's why you have to keep moving the muscle. Even any other disease, the mobility is important. So the Parkinson, the basic problem is the mobility. That means the nervous system. It's like the current is not going, no electricity is not going there. Yes. So the muscle won't work without electricity. So stimulation is one of the things, and giving tablets increase the transmitters. So your physiotherapy will help to maintain the muscle activity. It's actually a passive way of doing it. Once the things go on, you keep on moving. Somebody from outside, your active or passive movements will help to keep your muscle bulk. Otherwise, your muscle will get wasted, no, if you don't use it. So that's how it helps. But doing exercise itself, I don't think that's no. If somebody is going to get Parkinson's due to the depletion, either genetical factor or the environmental factor, they will get it. But once you get it at early stages, recommend physiotherapy so that the deterioration of the rate of immobility that will be less. We can slow down the process. So that's the way that helps. Exercise will help in that way.
But in terms of any cardiovascular disease preventive measures, like any long-term jogging or walking, and also diet controls, early stages, those things, eating healthy food, less red meat, eating healthier fatty acids, those things will help in terms of it. So mainly things is in mode of exercise, with the same exercises what usually we talk about for their heart patients, which also benefits for their, but it's not going to prevent from Parkinson's disease from getting it.
Question you answer.
Yeah.
Kavita.
One question is there asked by Kavita. So is this disease will be inherited?
Yes. Kavita, just we've gone back to the slides that that this autosomal 15% or below, that is autosomal dominant in characteristic. So that there's two genes. I will show you this particular slides. This one, can we reduce this one? And then here, that move this one out. So can you, there's a little bit, can you see the green slides at the bottom? Environmental factors and things, there are here, STN genes, log2 gene, SNCA genes. These are also then in head injuries, as we mentioned, pesticides and things, can predispose the symptoms and things. Such as eating healthier, yeah, and then so those things are there. The genetics is only 15% of it. So that in terms of the patients getting it, yes, there's a genetic linkage. 15% of the family history there. There's 15%. If you could see it here, 15% of the patients with Parkinson's log2 or genes, they are autosomal dominants in patterns. So just even one gene deletions can cause the Parkinson's disease if it's because it's autosomal dominant. Yeah.
Do you understand what is autosomal dominance and autosomal recessive? Because autosomal dominance means there are high chance of you'll get it. If somebody in your family got Parkinson's, and if it's due to hereditary, then you are more prone to get it. That is usually if the genes get from father and mother. So autosomal dominant is one person got, that's enough. Autosomal recessive other way, even if they both have recessive, you can escape. There's a chance, possibilities in the genetic science, you will study that.
Okay. The next questions, would the disorder reoccurs after complete recovery? There's no complete recovery in Parkinson's disease. It's just we are trying to stop the progressions, worst progressions itself.
Improve the quality of life.
So if you go back to the beginning of the slides, you would see this here. If I can enlarge, sorry, then go back to this one. Here, GI dysfunctions happens, frequent falls, tremors, all these things because the muscles are being wasted. And then you remember, all the GI tract, everything is muscular in nature. The food to move to everything else, the things also. So all these things, we can't stop it because the depletions of the dopamines in the substantia nigra. So that's is inevitably that part of the old age also we developed. Lewy body, for example, it comes in inevitably with the old age, as Dr. Pula mentioned, it's a wear and tear problems. So if you ask for a car to remain for 1,000 years, it's not going to be there, it's going to be wear and tear. So this is the nature of our design as human bodies things. So which is going to be these things, what we can do is reduce the tremors. The gait can be like the DBS doses, deep brain stimulation doses, improve the gait. So the patients can walk. As you have seen in the second video, this patient's unable to walk, then he was able to move his fingers, able to move them. So that's all we can do at the moment. Perhaps in future, we don't know. Okay.
Have you the feedback? These people, the Parkinson's people, they live a bit longer. They live up to 80s. When they develop 70, they live 10, 15 years with the treatment. If you don't treat them, they die early. So that's a benefit of having a treatment. Some people those regularly take the medication, and I don't think if somebody is going to get, not everyone get Parkinson's. Certain people, certain number of the population get the Parkinson's, and the treatment helps them to live a bit longer.
Doctor, this is Samuel. I have a question that in January 2020, there was study that says a new diabetes drug, that is GLP-1R. They say it can cure or it can be potentially used for treatment in Parkinson's. What's the
Yeah, there's something. Yeah, something I read about this deodenal secretion of treatment of something.
Yeah.
Yeah, possibly. I didn't study that one, so possible. That's what in future things could happen.
Okay. So how can students can research on that, or can we proceed with that, because it's a continuous process, right?
Anything is possible. The electronic era. Now something they can put some gadget inside and permanently stimulate the substance or Niagara. That these things they can find, they can invent it later.
Yeah. This is duodopa, so continuously pump in the gut also.
Yeah.
The future ones that they are using it is very less used at the moment. Sub-Q injections are used. And in our experience, there's some patients had the sub-Q injections. Then they go back into levodopa and dopamine agonist combinations of it to control the late stage of their 70s and 80s. The myos, catecholamines, and these ones have more, the Compton, MOPS, and these things have a lot more side effects. There are new treatments available, but there's something to say that in 80s, New York Times, they published, they found cure for the cancer, which is similar to that. News media, as they published, yes, they found possible cure. That's mean that's not a perfect cure for the disease itself, because as itself, the disease is a wear and tear disease. It's going to be very difficult to stop the God's design or the nature's design of our body, wear and tear.
Again, look at the nature. We are not going to make people live 100 or 120, 130 years. That's not possible. And all this new invention, we couldn't have in the coronavirus, isn't it? It's spread all over the world. But that has an advantage also. This Zoom technology developed because of the corona. Otherwise, I didn't know about this technology before. So things would happen, but the aim of the is just to prolong a little more, few more years in your life. But nothing going to be indefinite. No? So people have to die also. Otherwise, there will be population explosion. We can't survive. The world won't survive. So we can't beat the nature, but we can do small changes. Like when I was a medical student, we don't have all these facilities, all these mobile phones and all not there. Now a lot of things change within 30, 40 years. Things have been changed. We don't know what will happen in another 20 years time. So,
yeah, fortunately, the neurodevelopments and things, now they are, with the invents of the high technology, computers and nanomotors and things, they are talking in future, medicine is going to be completely different for 100 years from now, what we practice. That time, we might be able to send, nanomotors inside to eat out all the, Lewy bodies to everything else to repair it. We might live forever. But at the moment now, we are fragile human beings. And as physicians, what we can do is treat the conditions and then make the people's better as long as we can live, which is up to probably around 80s and 90s nowadays compared to 70s and 60s in Southeast Asian countries before. So as Dr. Pulo said, we are humans, we are, programmed to fail. Our DNA is not programmed to sustain for 1,000 years. So that's one of the point we had to understand.
Thank you, doctor.
Yes,
Thank you.
Thank you, sir. One more question is there in the chat box. What does the term brain fog refers to in Parkinson's disease? So what is the term brain fog refers to in Parkinson's disease? Brain fog.
Brain fog. They feel the dementia is also part of the brain fog because as they get, we covered on this few slides before, people tend to have little bit of brain, the dementia, late stage and things. They will also start developing slightly dementia. One is due to medications. One is due to the brain's, the problems, Lewy bodies, and everything else things. So they will definitely have what's called brain fog, which is dementia associated problems. Am I correct?
Yeah.
Yeah.
Yes, sir. Thank you so much. And also we have another question. Will the stem cell therapy cure nerve cells? Hello, am I
Could you
audible?
repeat that question again?
Hello, am I audible?
Could you repeat that
Stem
question
cell
again?
therapy cure nerve cells. Will the stem cell therapy cures the nerve cells? Here's a question.
Just in the hematology, that is, but in the neurology, I don't know whether. Yeah.
It's still in infancy stage. Neurons themselves less likely to regenerate. So then there's an issue. There's articles, they're coming up, they are finding a new way to do it. Again, another 50 years time, they think they can stop progression of these diseases.
You have to wait and see. But in the bone marrow, they do that, no? Stem cells, that's happening. But in the neuron is generally the regeneration of nerves is not found so far, but we don't know what will be the future.
Because they found in some tardigrades and some of the animals, the species, regenerations of the neurons, which they are trying to do it for human beings. But that's going to be trial and error years of research and development.
Yes, sir. Thank you. Thank you so much for answering the questions. Students, if you have any other questions, you can put it in chat box or you can raise your hand. We'll allow you to talk. So any other questions from the participant side? One question.
Dr. Polo? Yeah, Dr. Polo?
Yeah.
This is Lakshmi Mohan.
Yes, I can see you.
Doctor, I have visited Japan and discussed with Kumamoto University and Kumamoto Hospital.
Yeah.
I discussed with doctors and research scholars. I saw and read about one drug. They used this kind of Parkinson's. This is the dogs, I think so. I saw the video. in a Kumamoto Hospital and BMS Hospital Research Center also in Japan.
Yeah.
They used the drug and some of the patients also for Parkinson's through stem cells. Through stem cells. So I put the questions in the chat box. I only put the question in the chat box. Okay, I saw in they already started the research and research for Parkinson's through stems. This for your kind information, doctor.
Okay, that's good. I think I didn't know that.
Yeah. Because we heard about that developments is there, but it's not being ratified treatment as yet. So that it's early stage developmental theories, and they are doing lots of things now at the moment.
I have detailed report and videos also from Japan. I got Japan. I will.
And there's a quite interesting new technologies are coming up in each medical sections, and they say that in 100 to 150 years, it's going to be a complete different way to be practice medicine. So with these developments now.
Okay.
Dr. Raviran, for your kind information, the research head from biomedical department only.
Okay. Learned that from you.
Yes, sir. Thank you so much for all your inputs, sir.
EMS, yeah.
Yes.
VMS hospital. We'll look into it.
Yes. Thank you so much for all your inputs on this topic, sir. So is there any other question? I think we have done with all the questions, sir. So I think we can conclude the session if there is no more questions from the participant side.
Okay.
Thank you very much for giving us the opportunity.
Yeah, thank you, sir. Thank you. We'll formally do it, sir.
Okay.
Sandhya ma'am, yes ma'am, please conclude.
Okay, in the long run, we consider this collaborative education. London, Pondicherry, and Jaffna, Sri Lanka. So exchange programs. So you can do it online teachings. The knowledge sharing. Knowledge sharing, no, we can do that soon. Okay, we can affiliate to you on knowledge sharing. Professor Lakshmi, that for your thinking, I am leave it to you to decide.
Yeah, this is a great pleasure, Doctor. This is a great pleasure to join hands with you, your team. Thank you for the opportunity, Doctor. Thank you for the opportunity. Myself and Dr. Ravindran will discuss and interact with our management and get back to you soon, Doctor.
Okay.
Okay. Thanks.
Yes,
thank you, Mr. Prabhakaran.
Yes, sir. Thank you so much, sir. Madam, madam, you can do it. Sandhya, madam, yes, you can go ahead.
Okay, sir.
I've unmuted it.
So as an end comment, I would like to sincerely thank our management for permitting us to conduct this international webinar series. I would like to thank our today's speaker, Dr. Saravanamuthu Boologanathan, for sharing the valuable insights about Parkinson's neural disorder and its treatment. I would like to thank our HOD for his graceful support extended towards this webinar session. I would like to thank our fellow faculty members for the wonderful coordination. And finally, I would like to wholeheartedly thank all participants from different locations for your presence and making this international webinar a grand success. Once again, thank you all. Thank you.
Thank you.
Thank you, Dr. Shankar. Also, he did most of the work for me.
Thank you, sir. Thank you.
Thank you,
my
Dr.
pleasure. He's my guru. He's far ahead. I am just here at the bottom.
He is guru for us also, sir. Doctor, he is us also.
Okay.
Yes, sir. Thank you so much for
Thank
all
you,
your
Dr. Shankar.
We'll talk again.
We'll meet in person because I think my father also taught at a university when he came to Uda Tamil Sangam. Yeah, so we'll meet again.
With pleasure, Dr. Shankar.
Okay.
Yes, sir. Thank you, sir.
Thank you, Doctor.
Bye.
Thank you, Dr.
Bye, sir. Yes.
Thank you.
Bye,
We'll
bye,
wind
bye.
up, sir.
Thank you. Thank you, biomedical professors, team, faculty members, students community. Thank you. Thank you, Dr. Ravindran. Thank you very much.